After I prepared this talk, I was emailed some links by Merrin, and I freaked out that there was an adult presentation on chronic pain last year. So humblest apologies if you attended this and this is a bit repeated. Although, to be fair, children aren't small adults. Plus, they tend to have different disorders from adults in chronic pain. Adults have lots of scary stuff like all those degenerative rheumatological issues, low back pain, endometriosis, chronic pelvic pain, etc. Children don't have. I think the good thing about children is that we in paediatrics feel that those children that have chronic pain tend to have a better prognosis compared to adults. Although this is maybe just because we discharge them once they get to 16 years of age, so we never hear about them again. So that's what attracted me to paediatrics when I first started thinking about what I could do. Because I was actually thinking of being an adult gastroenterologist and then thought adult medicine was just dreadful. And one of the paediatricians in Southland said, paediatrics is wonderful. Most of them get better and they go home, but if they get to 16, they're someone else's problem. So my talk today is going to have some cases from patients I've been involved with over the years, some of which went well, some of which didn't. Interspersed with these case examples will be how, and I say we in general paediatrics, so it's a bit of a disclaimer, it's not really like starter policy, it's just how we've kind of evolved at how we approach chronic pain referrals in general peds. Like I said before, we kind of have actually quite limited access to multidisciplinary services in the outpatient settings like physio, psychology, occupational therapy, which is the kind of gold standard approach. But we do so in the inpatient setting. So our approach in general peds is, again, this good enough approach rather than a gold standard stuff. There is a chronic pain clinic at Starship. It's fantastic, but it can have a 4 months or more wait list at times. So what we try and do is incorporate some of the strategies, have a kind of practical approach to get the ball rolling, and hopefully the kind of ship would be turned around. So my talk's going to be focused on some practical strategies with some evidence-based that hopefully might be helpful for you guys in primary care, rather than a gold standard approach, which is hard to replicate with wait lists, finding staff with that expertise, which may or may not be available in your area. And again, if you've got questions, if you've got tricky cases, you want to talk about them, that's great. You can brainstorm. I don't have the answers, probably. So first case. So Joanna, 14-year-old girl, episode of loose bowel motions and abdominal pain in February. Now the family lived rurally, they were on a tank water supply, but no one else in the family was unwell. Went to the GP, quite rightly diagnosed with gastroenteritis. Off school for a week, went back to school, but home within 2 hours, excruciating abdominal pain. So from then things kind of escalated. You've probably seen this before. Frequent visits to the GP, and as a big GP practice, quite a different, it wasn't the same person each time. Various urgent doctors, North Shore Hospital, Starship ED over the next 4 week period. So increasing abdominal pain, got up to 10 out of 10 intensity. Increasing difficulties with eating, increasingly unable to get out of bed. Because of this, her mother had to take time off work, so there's a financial implication. Granny had to move in. There was subjective weight loss, and a number of the GPs and urgent doctors had done bloods, all of which were normal. Got a stool specimen several times, which was normal, and even had an ultrasound as an outpatient, which was normal. So she was actually admitted under general peds in early April for several days, but it was over the weekend, and we all know nothing happens over the weekends in a hospital. So she appeared pretty well. She had some tenderness in her central abdomen. Weight was 85 kilos, so certainly not failing to thrive, and appeared to be eating normally in clinic. So there's a Subway in Auckland Hospital. It used to be a McDonald's, actually, and that was the best test of all, but not very PC to have a McDonald's in a children's hospital, so got rid of that a few years ago. Anyway, so she had some repeat bloods. HB was normal white cell, CRP less than 1, you can read all that. SEDAX serology had been done several times previously, but repeated again for what it was worth, totally normal. Also got an abdo x-ray and another ultrasound, all normal. So she was kind of discharged home after a couple of days, diagnosis of presumed post-infectious abdominal pain, whatever that is. So things kept escalating. Several more visits to the GP and Starship ED. For some reason she got a fecal calprotectin done by a house officer in ED. It was 515, so normal less than 50. So now what? So she was referred to Peds Gastro. Does she have inflammatory bowel disease? They did a full range of investigations. So upper GI scope was normal, colonoscopy, there was one tiny little ulcer at the terminal ileum. The biopsy was non-specific, certainly not characteristic of Crohn's. She had an MRI small bowel, some non-specific inflammation, and even went through for a capsule endoscopy, so all the fancy stuff, a couple of tiny little ulcers. So she was diagnosed with mild Crohn's disease, but the gastroenterologist was not that convinced about it, but kind of went down the pathway. They were given a lot of information to read, which the family read everything, everything on the internet, they told me, all the books, everything. And also joined several Facebook groups as well. So I kind of think, what's a successful turf to GI? Yeah, but nah. Thanks. So she went down the Crohn's pathway. Got a trial of prednisone, unsuccessful. Trial of enteral feeding, unsuccessful. And the pain just escalated. Now it was totally localised to the right lower quadrant. That was following the investigations. And also started to have some extra GI manifestations on history, so complaining of joint pains, red eyes, but these were never really seen by anyone. And she was basically incapacitated at home. No school since early February, increasingly unable to eat, so she was only on Pediasure, and repeat bloods were normal, calprotectin was improving. So the poor old gastroenterologist was like, help, and there was multiple emails going around. So ended up she represented to Starship ED, mum refusing to leave until something was done. ED inserted a nasogastric tube. She hadn't eaten in 72 hours apparently, hadn't drunk in 24 hours, but no evidence of dehydration. Unfortunately, I was on call. I was feeling very sorry for myself at this point. And actually what I tend to do in these situations, because usually what happens is the tertiary guys are like, no, this is not us under general peds. And I actually, it's a bit rough on them, I actually refused to have her under me until the family and me and gastro all met together, because I could just see this turning badly. If I waltzed in and said, that Crohn's stuff, nah, it's all chronic pain now. Because there's no way anyone was going to accept it. They've gone down this medical pathway, and turning that around is hard. So I said to the gastro guys, look, we have to have a joint explanation of why Crohn's is not likely. And you've got to say that. We've got to explain the multidisciplinary approach, which I'll talk about that. Have a defined, this is what I was telling gastro, we define 2-week admission. The family have to be on board. They have to accept things. Otherwise, I'm not taking over care, which was a bit rough on them. Gastro, that is. So we had a 2-hour family meeting, which, in June, had about 40 odd inpatients. It's hard, but I kind of feel in these situations, if you front load it, hopefully things will get better. So we had to explain why Crohn's is now unlikely, which the difficulty is when people are invested in a medical diagnosis, and trying to turn that round is really hard. And the reason is because there was minimal ulceration to start off, which she probably did have gastro, The pathology report wasn't supported. She always had normal bloods. The fecal calprotectin was improving. And then the family said, well, look, if it's not that, what is it? So then we started talking about the chronic pain, or, as we call it, central neural hypersensitization process. So sometimes we do admit these kids. And I know someone sort of said they're not keen on patients being admitted, but what we've found is that we can kind of fast track the rehabilitation process if we admit them. But what we've learned over the years with these kids is that the family have to be on board with this process. And if they're not, we discharge them. So what that means is they have to accept our explanation, and I'll talk about the science and how we explain. I explain it. We have a hospital school. They have to go to school, non-negotiable. For Joanna, we slowly reintroduction of food. Input from a psychologist is also non-negotiable. We're pretty strict. I went to boarding school, so we have a daily plan, and it's basically like boarding school, which is you will get up at this time, you will have a shower, you will go to school, it's really structured. No electronics after 7 p.m, bed by 8 p.m. So for a 14-year-old, this is... And one thing I'm personally in favour, and I often write this on the drug chart, is daily walking twice a day. Okay, so I actually prescribe it. The nurses all laugh at me, but it's just to try and get some normalisation of function. And if people don't accept the plan, if the family don't accept the plan, we discharge them. Because what we've found with other cases is they kind of get stuck. and start sacking team members when things don't work. So luckily for Joanna, she had a really sensible extended family. There was a granny with previous chronic pain issues, but she'd gotten through it. She told me I walked it off, and when we did a heads assessment, there was a lot of things came out. There was a really traumatic parental separation about a year ago. She had CRIPS 3 years ago. I'll talk about CRIPS. I've got a little segue into that later, which no one had really had got lost in the midst of time. There was some friendship conflicts at school recently, and also a lot of escalation from the mum about, and quite rightly to be fair, because there was this diagnosis of Crohn's. She actually did incredibly well on the ward with this process, we call it the rehabilitation process. So I was feeling really smug. She made good steady progress. Her MG was out after a couple of days. She was eating after a few days. Mum went home for a weekend. We love it when there's a bit of a parentectomy. And it just means we can get function going. We have a fantastic play therapy staff. She really bonded with one of them. She was walking to and from school and to the domain. We don't tend to ask them about the pain. Now, I had a new registrar who wasn't from New Zealand, who couldn't really get her head around the fact that I said, you are not allowed to ask her about the pain. She did have a lot of analgesic medications that had been prescribed that she'd been taking, very religiously. So I put it on the PRN part of the drug chart, which we all know what that means. So you think it means as required?
No, never.
Patient receives nothing. We give it to them if they want it, but they've got to ask for it. We don't give it to them regularly. So, like I said, I'm a bit of a minimalistic. Okay. So, and she made friends on the ward. We have quite a lot of teenagers. We have a lot of eating disorder patients as well. And you kind of think, oh my God, she's going to catch an eating disorder. But they don't. They kind of, things. And there was lots of activities, lots of arts and crafts. It's kind of fun. It is a lot like boarding school, I can tell you. So, and she actually went home after 10 days. So we had a 2-week defined period, but she was in a double room. It was winter. We had an early influenza outbreak. There was a lot of crying bronchiolitic babies. That's very encouraging for people who get home. So I was like, yes. So how were things in outpatient clinic? So it was kind of good. Yes and no. She was, at that point, attending school 2 to 3 hours a day. Now, this is someone who hadn't been at school for about 3 months, so it was really good. But no exercise, which, I'm a big believer of exercise. She was eating a full diet. She had some sleep initiation problems and still complaining of joint aches and pains and that. So kind of there, getting there. So I did actually do some repeat bloods, and this is a really reassurance thing. And again, my fingers and toes were crossed, and the fecal calprotectin was normal. So my approach, I tend to try and jolly things along. I really emphasise function before pain resolution. We'll talk about that. Limitation of electronics for sleep side of things. Daily walking, non-negotiable. And like I said, we really struggle to get psychology input. Waitlist is huge. But a number of GPs up in Auckland do have access to some things like CBT through the GP, so we often try and do that as well. So Mum is still really fixated on Crohn's, asking about medicinal cannabis. This and probiotics. But I kind of ignore that and kind of, again, the emphasis on function. Normal investigations meant that Crohn's was unlikely, very unlikely. We talked about anxiety and catastrophizing, focusing on this medical stuff, not getting through the rehab process, and the conscious need to move on. So it was kind of a work in progress. When I was writing this talk, one of my buddies who works in the chronic pain service actually rang me up, and because they were actually booked to see her and saw I'd been seeing her. So she had been referred in April. So appointment with the chronic pain team was August. So that gives you an idea of our wait list. But at that point, she was walking 20 minutes a day. So I was really thrilled about that. She was school largely full-time. And actually, coincidentally, I was just rung up by the Northern House Schools teacher who said she's now going to full-time the last week. So that's fantastic. Still complaining of pain. Unfortunately, she'd had a recent bout of diarrhoea and an urgent doctor did a fecal calprotectin. But she was going to school. So it's going to be one of those ones I think I'll have to get the gastroenterologist again to say this is not Crohn's, which will be tricky, but it's getting there. So that's one of my patients. So what's the definition of chronic pain? So commonly accepted definition is pain for more than 3 months duration. And so it's kind of pain that extends beyond the usual period of tissue healing, so especially if you had an injury. So, but it's entirely reasonable that if a person has pain and you think they've got chronic pain and it's only 1 month, but they've got no evidence of an organic disorder, and they've got the setup for this kind of chronic pain situation, the central neural hypersensitization, that you can give the diagnosis earlier. It's pretty common, said to be 20 to 35% of young people worldwide, and more than 10% of hospitalised patients. And about 3%, so the point end of the stick, need intensive rehabilitation. And there's a lot of costs. School non-attendance is a big one, and I'm sure you guys have heaps of patients with these sort of issues. Costs of primary, secondary care, parents being off work. I mean, we've had a number of patients, the parents have given up their job and, assume the carer for the child, and also obviously allied health costs as well. So it's challenging, it's time consuming, and it can be really hard to deal with, quite frankly. But if things improve, which they can do in a number of cases, I find it really satisfying. I love it when they don't come back to see me. I kind of think no news is good news, hopefully. So what about the physiology of it? So I'm not a scientist, I'm not a chronic pain specialist, but I like to try and explain the science, because I kind of think if people understand it, then they think we're not thinking it's in their head, and they can kind of see the process that's happening and why we recommend the rehab approach. Now, this is one slide I found explaining chronic pain at a glance, and I thought, my God. And I thought, jeepers, how do you explain that? And I won't go through this in detail. It's too complicated for me as a general paediatrician to understand, let alone anyone else. So this is kind of a more civilised explanation. And my kind of simplistic explanation to you guys and to myself is that there's a number of peripheral neurons that sense pain. There's these C fibres, lightly myelinated, unmyelinated A delta fibres, and they bring pain to the spinal cord. And in the spinal cord, there's a whole lot of modification that goes on with pain, and before it's relayed to our brain, where pain is perceived as a result, with all its kind of emotional and aversive consequences. So we often talk about a condition called central neural hypersensitization syndrome, which is chronic pain. So this is where you've had a trigger in the peripheries, and it leads to central sensitization, so in the nerves and neural spinal circuits, and it results in the pain being ongoing, despite the original trigger long gone. And so what peripheral sensitization is thought to do is that there's a reduction in the threshold of pain, because we all kind of get little feelings on ourselves, and our brains filter them out, our spinal cords filter them out. It's like, say, someone said to me, an analogy is like sitting in an airline seat, if you're flying to London. You never get pain if you're sitting in business class because you're lying flat. But if you're in a normal seat, a few hours you're fine, but at the end of 24 hours, you've got all these aches and pains and that. So it's a reduction in the threshold or increase in responsiveness to normal triggers or stimuli. And there's various chemical mediators that can help maintain this process, cytokines, prostaglandins, leukotrienes. And at the spinal cord, these trigger the release of various neurotransmitters like glutamate, asparaginine, which then acts on various receptors. One's called the NMDA receptor, which we'll talk about a bit later. It releases another substance P, which enhances by lowering the threshold. And also, in response, there's things like microglia and astrocytes, and also immune cells that kind of, basically it all acts to be a constant forward feedback loop which maintains chronic pain. So that it's basically these signals are kind of ongoing, and that. And big question is, why does normal pain, like you fall over and you sprain your ankle, for most people that resolves, but in some people leads to this ongoing maintenance chronic pain. Bottom line, don't really know. Could be genetics, could be, what we've learned as children, how people have responded in the past to pain, anxiety, what's going on in life, and all the rest of it. But for most of us, we don't get chronic pain. And it's because we've got these what we call spinal inhibitory networks. So things are dampened from, it's not all coming up, it's dampening down as well. And that acts to reduce persistent peripheral pain and central hypersensitization. And that's probably due to some inhibitory neurotransmitters like GABA, glycinergic as well. But in some people, those that get chronic pain, these inhibitory networks are turned off as well. So you can kind of think things are coming up, but also the downward dampening down's not happening. So I try and explain that, and usually people's eyes glaze over. So this is another slide looking at what's happening in the spinal cord. So you can kind of see there's a lot of different things going on. There's the microglia and astrocytes, the immune cells, and that process is just on a feedback loop. And this is another more detail. So it's really complicated. It's hard to explain. I find it difficult. I do a very simplistic explanation. However, it is really good to communicate the science. And there's a chap, I don't know if you know about him, called Lorimer Moseley. He's done some TED Talks, and I've heard him speak at a couple of conferences. He's an Australian physiotherapist who's published and presented a lot on chronic pain. And he's published some studies showing that there's actually really quite clear evidence that teaching patients accurate knowledge about the biology of pain is associated with increased pain thresholds, so they're not getting as much pain. Also, reduced pain frequency, improved function, and reduced catastrophizing. So I do spend quite a bit of time explaining the biology. But that stuff's hard. I'm not a scientist. How to explain that? So sometimes I use this very basic thing to show the things coming up, modifying at the spinal cord, and also dampening those down. But I find that one good analogy is worth 3 hours of discussion. So what I generally do, have evolved over the time, is when I see patients in the outpatient and inpatient setting in whom there's been a lot of investigations usually done, they're usually normal or no explanation of the pain. Often what's happened before they've seen me is someone suggested a psychologist, which often is interpreted by the family as they're saying it's all in my head. And they get very defensive and frustrated and all the rest of it. And when we're kind of seeing patients with chronic pain, we're talking about the rehabilitation approach, which seems to be counterproductive because I've got pain, so how can you rehabilitate and move? And the rehabilitation approach, which I'll talk about, is sort of more movement, attendance at school. Often people want a medication to help it, but you can see from that science, one medication is not going to sort that. Even a few medications are not going to sort that because it's really, there's the big thing going on there. So that's why I spend some time explaining the physiology, show them that there's not an easy solution. One pill will not rule them all with regards to pain management. And also, obviously, there's the belief that if you have pain, there must be something wrong. And as one parent said to me, you fellas are missing it, as in we haven't got the diagnosis. And also there's the other belief that if you rest, the child rests, the pain will eventually resolve and then normal activities can resume again. But that doesn't happen in chronic pain. It's the opposite is true. And what we see, and you guys probably see a lot as well, is that rest and deconditioning tends to actually make things worse long term in these situations. I had one patient who rested for 8 months and told me that the pain was worse after that than was the beginning. But also what they also do with pain, they get a lot of sympathy and attention, and that's really counterproductive. But more on that a little bit later. So how to deal with a conundrum or try and explain that complicated science and all those slides I set with marrying up with a rehabilitation approach, which includes movement, which they don't want to do, going back to school, which they don't want to do, a psychologist, which they definitely don't want to do. And so in a way that people don't feel that it's all in my head because the investigations are normal, therefore there's nothing wrong. So what I tend to do is use a few analogies to try and help explain the science. I tend to draw pictures. I'm useless at art, so everyone laughs at my pathetic pictures. But talking about the nerves from the periphery to the spine to the brain and back again. But the analogy I tend to use is the burglar alarm, the house burglar alarm. And I always say something like, we've all walked down the street and we've heard someone's house alarm going off, and there's clearly no burglars in the house, but the alarm's going off. So what I say is the alarm's gone off, it's still ringing. There were some burglars previously, but they've long gone. But the alarm is still ringing. But the worst part about the alarm, which is the pain, is that initially it's quite quiet. It's like an acoustic guitar. But what the problem is, because it can't turn itself off and no one's sorting it out, that it tends to amplify. It's like a guitar amplifier, which is the spinal cord is the amplifier, which cranks up the volume, and it ends up being in a forward feedback loop, which is getting louder and louder and louder, even though the burglars have long gone. Other people have talked about a broken alarm clock. So chronic pain is a bit like an alarm clock that goes off at 6 a.m. You hit the snooze button, it keeps going off. You hit the snooze button again, it still's going off. You bang the clock, you unplug it from the wall, you take out the batteries, it's still going off. So that's another analogy. Other people have talked about analogies like being a software problem in the computer. So the body is the hardware of the computer, so our bones and our tendons and our muscles and our ligaments. But whenever our computer freezes or crashes or the IT doesn't work, it's not the hardware, it's the software. And the problem is, with chronic pain being a software problem, we can't test for the software. So the rehabilitation approach is a bit like Control-Alt-Delete, but never that fast. So you kind of think, does this actually work, or is it a load of rubbish? But there was actually a really nice study in 2013 that by a chap called Gallagher et al. In the Clinical Journal of Pain that showed that in two groups of chronic pain patients, in one group they used these various metaphors and analogies, and it resulted in an increased knowledge of pain biology, and it actually ended up with reduced catastrophic thought processes about pain because they had an explanation. That's something that people could wrap their heads around, bit of the science, but analogies of why the pain is going, compared to the general group who just received normal general education and advice giving. So there's some evidence that trying to use analogies to explain pain. So going back to our patient, this is not projecting well. History and examination can take some time. So I have 60 minutes in public sector. I actually insist on 90 minutes in the private sector. So I can able to take a really careful history of pain, but they're new to me, to be fair. So I take a detailed history of the pain, when it started, the pattern over time, presence of a thing called allodynia, so that's pain with light touch. Things that could worsen the pain, usually it's everything. Anything that helps the pain, usually it's nothing. And also what they've trialled so far, who they've seen, traditional, alternative. And it always amazes me is how much money people have spent on this. I don't know if you guys see that, but the alternative industry or complementary industry is, it gets a lot of patients. So, and what advice has been given. I always ask about other functional somatic effects like fatigue, nausea, joint symptoms, sore throats, viral infections, that sort of thing as well, effect on sleep. And I really kind of go through any past history of pain, trauma, operations, premature birth, hospitalisations. And the reason why I ask about these things is those previous events can sensitise the neural system, so making it more likely to develop chronic pain. So an example is with prematurity. Now, in my training, I worked in neonatal units for many months, and premature babies are subjected to a lot of painful procedures, heel pricks, nasogastric tubes, chest positioning for chest x-rays, and we use analgesia like sucrose, but these are clearly painful because the kid cries when that happens. So in ex-prems, we know are higher risk for the later development of chronic pain, presumably because of sensitisation of that central neural system, so it's primed in that. And kids over the age of 10 years, I do a HEADS assessment with the parent out of the room. So as you kind of well probably know, it's home, education, employment, exercise, eating, drugs, sexuality, suicide, safety, strength and spirituality. And I also go through the family structure, and I really ask has anyone had, and rather than I used to do, any past medical issues in that, because people won't tell you unless you name all the conditions. So I say, have anyone had fibromyalgia? Have they had chronic fatigue? Have they had an eating disorder? Have they had anxiety? Have they had headaches? And if the history is positive, I always ask what the person who had that condition, what treatment did they go through? Have they got better? And whether there's any ongoing issues. And obviously the family structure, we want to know who's in the house and all that side of things. So examination, I realised I forgot to put growth in that. Growth's really important, but I go through everything. I examine them, I work out their height velocity, because this is quite a sensitive marker for organic disease. I always say, also when I examine them, I also see what the parent is saying, like, tell the doctor where it hurts, or don't touch them, it's very painful there, type thing, which is a lot of social reinforcements for pain. So when I see the kids, I chat to them and say, oh, what are you doing in the weekend? Do you have any brothers or sisters? Do you have any pets? Or what do you like to do? And see how they respond to that distraction. So hopefully what I'm trying to do is model the introduction of distractions as a treatment as well, to the parent, that is.